Red blood cell transfusion in critically ill adults. In the United States, approximately 5 million patients are admitted to intensive care units annually. Among these, 1 in 4 receives red blood cell transfusions, accounting for approximately 1.8 million units per year. The primary indication for transfusion is low hemoglobin levels, which account for 80% of cases. Other reasons include active bleeding in 27% and hemodynamic instability in 23% of cases. While red blood cell transfusions are life-saving in specific situations, they carry risks such as transfusion-related acute lung injury, transfusion-associated circulatory overload, and immunomodulation, which may increase the likelihood of hospital-acquired infections. Given the high costs and limited availability of red blood cell units, it is important to prioritize evidence-based use to optimize care and resource allocation. Key hemoglobin thresholds. A restrictive red blood cell transfusion strategy involves initiating transfusion when the hemoglobin level falls between 7 and 8 grams per deciliter. This approach has been shown to be safe and effective for most critically ill patients. In contrast, a permissive transfusion strategy involves transfusion at higher hemoglobin levels, typically between 8.5 and 10 grams per deciliter. This approach may be appropriate for select patient groups, such as those with acute coronary syndromes, who require individualized management. Clinical recommendations. For critically ill patients in general, a restrictive red blood cell transfusion strategy is recommended, as it is associated with similar or better outcomes compared to permissive strategies. In patients experiencing acute gastrointestinal bleeding, a restrictive approach is also preferred, as supported by modern quality evidence. In patients with acute coronary syndromes, a restrictive transfusion strategy is not recommended due to the potential for harm. For those undergoing cardiac surgery, a restrictive transfusion approach during the perioperative period is suggested, as it aligns with available evidence. In cases of isolated serum troponin elevation without other signs of cardiac ischemia, a restrictive strategy is suggested, although the supporting evidence is of very low certainty. For patients in septic shock with evidence of end-organ hypoperfusion, permissive thresholds are not advised as part of usual care. Clinical implications. The adoption of a restrictive transfusion strategy can reduce the number of red blood cell transfusions by approximately 40%. In the United States, this reduction could spare around 500,000 patients from unnecessary transfusions annually. Hemodynamic instability is often a key factor in deciding transfusions and is characterized by hypotension, with a mean arterial pressure below 65 millimeters of mercury or systolic blood pressure below 100 millimeters of mercury, and signs of tissue hypoperfusion. Patients with acute coronary syndromes require individualized thresholds due to their unique clinical needs. Limitations. The quality of the evidence supporting these recommendations ranges from moderate to very low, particularly for patients with acute coronary syndromes and septic shock. Additionally, the studies reviewed did not assess factors such as the age of stored red blood cells, donor characteristics, or specific processing and storage methods. These gaps highlight the need for further research to refine transfusion practices. Conclusion. Restrictive red blood cell transfusion strategies are supported by current evidence and represent an effective way to optimize resource use while minimizing transfusion-related risks for critically ill patients. Clinical decision-making should remain context-specific, particularly for patients with acute coronary syndromes or septic shock.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.